Thank you, Chairman, for your kind introduction, and I really appreciate the organizing committee of this wonderful symposium in Vietnam. I will talk about the current and new biomarkers in HBV infection associated with hepatocellular carcinoma. This is my COI. Today, I will talk about the two main body of story, the current biomarker and new biomarkers of HBV-related hepatocellular carcinoma. This is the table of content. I will start by introduction. High prevalence of hepatocellular carcinoma in Asia is strongly associated with HBV infection. You can see the red and orange part around the world that indicate a very high rate of HCC occurrence. These parts mostly include Asia and Africa, where HBV infection is endemic. Therefore, the control of HBV infection is crucial to prevent hepatocellular carcinoma development. Early diagnosis of hepatocellular carcinoma is very important to make patient prognosis be better. The most guidelines recommend ultrasonography with alpha-fetoprotein, AFP, which is a traditional tumor markers as a HCC surveillance modality. However, the ultrasonography only is not perfect for HCC surveillance. The accuracy of ultrasonography is superior to alpha-fetoprotein only, but not so ideal. The sensitivity of ultrasonography is from 65 to 80%, and specificity is over 90%. This accuracy issue can be explained by technical problem. It is very difficult to find regions of blind area like a liver dome and peripheral area and infiltrative type of HCC by ultrasonography. Therefore, the need for tumor biomarkers are continuously increased. This table summarizes the HCC surveillance guideline in Asian countries. Especially the Japanese guideline recommend 3 tumor markers including alpha-fetoprotein, the PIVCA2, and AFP-L3. I will discuss these tumor markers later more in detail for high-risk patients for a 6 months interval. There are several factors determining the prognosis of hepatocellular carcinoma. Those factors are tumor factors, which include tumor burden, number, and presence of vascular invasion, and extracellular metastasis or tumor pathology, on-treatment response evaluated by imaging, and lastly, tumor marker level. Diagnosis is also very important to predict the tumor prognosis. Biomarkers in HCC are usually molecules directly produced by cancer cells or as an effect of a tumor on healthy tissue. Besides, there are serum proteins, oncofetal antigen, hormone, metabolite receptors, enzymes, or genetic materials. Above all, ideal biomarker should have high sensitivity, high specificity, and good correlation with the tumor progression and the prognosis. Let's look at the current biomarker for HBV-related HCC. As you know, alpha-fetoprotein is a representative tumor marker of HCC, which is elevated in 50 to 80% of HCC patients. However, as it reflects hepatocyte regeneration, it is not specific to HCC, and it can be elevated in benign situations like chronic hepatitis or cirrhosis as well. In addition, the role in early detection of HCC is limited because of low sensitivity of alpha-fetoprotein. This study was conducted in our center. A total of 392 patients with cirrhosis were regularly followed up. The combining alpha-fetoprotein and ultrasonography increased both sensitivity and specificity of HCC detection. This combination is superior to the alpha-fetoprotein only or ultrasonography only. In a Korean study, a total of 1,255 patients with chronic hepatitis B were retrospectively enrolled. PIVCA2 DCP might be better tumor markers than AFP. When it combined with alpha-fetoprotein, the early detection of a hepatocellular carcinoma was enhanced. Based on the meta-analysis of 27 studies, the diagnostic performance of a combination of alpha-fetoprotein plus PIVCA2 is prominent to that of either biomarker alone in detection of HCC. So I highlighted that both tumor marker combination is better than one either. I will share the data from our Center of Yonsei University. A total of 702 patients with compensated cirrhosis were regularly followed up. Among them, 307 patients were available of both alpha-fetoprotein and PIVCA2 DCP, which were measured every 3 months. After excluding the patient with protocol violation, a total of 176 patients were finally analyzed. During the follow-up, 24 patients developed HCC. This table shows the characteristic of 24 HCC patients. Most of them are BCLC stage A. At diagnosis, 54% of patients had alpha-fetoprotein greater than 20, and only 21% had alpha-fetoprotein greater than 200. Similarly, the 58% of patients had a DCP, PIVCA2 greater than 40, and only 29% had DCP greater than 150. The half of patients showed a positive ultrasonography finding at diagnosis. We learned from these findings that tumor markers or ultrasonography only is not sufficient to detect HCC completely. Alpha-fetoprotein by itself showed a higher specificity but low sensitivity. PIVCA2 had a slightly higher sensitivity compared to alpha-fetoprotein alone. The best cutoff value in this was around 8 in alpha-fetoprotein and 38 in PIVCA2. This is another study from our Yonsei University. Consecutive 1,447 HCC patients were assigned to 4 different groups according to the cutoff value of both tumor marker, alpha-fetoprotein 400 and PIVCA2 100. 4 groups consist of both tumor markers high or one of tumor markers high or both tumor markers low. So these 4 groups. Okay, you can see this graph showing the cumulative survival rate according to the groups. The overall survival rate showed a significant difference among the 4 groups. The group of both tumor marker low had a favorable outcome, and the group of both tumor markers high showed the poorest outcome. The PIVCA2 level indicate poor prognosis compared to alpha-fetoprotein levels. The 5-year survival rate was only 11.5% in the group of both tumor markers high level. It reflects that the baseline alpha-fetoprotein and pivotal level might be helpful predicting tumor prognosis. The significant differences in survival among the 4 groups were identified in each TNM stage as well. The low baseline level of tumor marker predict better survival in TNM stages 1, 2, 3. However, in stage 4, tumor markers are not useful to predict prognosis due to the very short survival of patients. We also investigated whether preoperative tumor markers can predict HCC recurrence after curative resection. 267 patients were divided into 2 different groups. The group pre-op 1 defined as both tumor marker elevation, alpha-fetoprotein and PIVCA2, and the group pre-op 2 had only one tumor marker elevation or both tumor markers very low. The pre-op 1 group, which is both tumor marker elevation, was associated with higher recurrence rate and shorter disease-free survival after curative resection. Therefore, the combination measurement of these tumor markers before surgery may be a prognostic factor for future HCC recurrence. A subfraction of alpha-fetoprotein called AFPL3 has been used as a diagnostic and prognostic marker of HCC. Alpha-fetoprotein L3 is secreted by malignant HCC cells in the early tumor stage, even in the absence of elevation of alpha-fetoprotein. Therefore, alpha-fetoprotein L3 levels make it the promising early screening tool. In addition, the new generation of assay has enabled the accurate measurement of AFP-L3 percentage at very low alpha-fetoprotein concentration. AFP-L3 can be detected in very low level of total AFP. Several studies showed high-sensitive AFP-L3 is a good biomarker for the diagnosis of HCC, even at low total alpha-fetoprotein level. This Japanese study demonstrated that the high-sensitive AFP-L3 is useful for detection of HCC in patients with a low AFP level. The sensitivity of a high-sensitive AFP-L3 in stage 1 and 2 were around 35% and 42% respectively. The combination with DCP improved the sensitivity compared with the AFP-L3 alone or DCP alone. Even the patient with a normal AFP level less than 10, the diagnostic rate of HCC is still high in combination of these 2 tumor markers. This is an interesting study that showed the usefulness of AFP-L3 to predict HCC recurrence after curative treatment. A total of 414 HCC patients who underwent resection or RFA were investigated and prospectively followed up. There were significant differences in recurrence-free survival between the groups with and without AFP-L3 elevation before and after treatment. AFP-L3 elevation before treatment and sustained elevation after treatment were predictable of HCC recurrence. Therefore, the repeated measurement of AFP-L3 could be performed for HCC recurrence surveillance after curative treatment. This is our retrospective study investigated the effectiveness of tumor markers in detecting HCC in cirrhotic patients. The AUROC, you can see the right side of the curve, the AUROC for combination of 3 tumor markers was superior to that of any one of tumor markers alone. If HCC patients have many of elevated tumor marker diagnosis, their cumulative survival rate lowered over time compared to those with none or smaller number of tumor marker elevation. The number of tumor marker present clearly reflect the extent of HCC and patient outcome. Let's move on to the new biomarkers. This table listed many of potential new biomarkers for early HCC detection regardless of underlying disease. Today, I'd like to introduce hepatitis B virus core-related antigen, which might be one of the new biomarkers, especially in patients with HBV infection. HBV core-related antigen consists of 3 precore core protein products: hepatitis B virus core antigen, E antigen, and 22 KD precore protein. Theoretically, all protein components are translated from CCC transcript. Therefore, the core-related antigen exclusively reflects CCC DNA transcriptional activity. There is only one commercial core-related antigen also available from Fuji Company in Japan. Core-related antigen can be used for various purposes in treatment, naive and antiviral treated patients with chronic hepatitis B. The lower core-related antigen are associated with a favorable outcome. Recently, the role of core-related antigen as a tumor biomarker has been highlighted, especially in HBV-related HCC. The core-related antigen may complement HBV DNA level to predict HCC development. The predictive value of serum core-related antigen for development of HCC in treatment naive patient was firstly reported by Tada et al. In Japanese study. Core-related antigen level over 2.9 log was associated with more than 5-fold increase in HCC risk. And together with Hong Kong study, the Taiwan study was the largest. Among E antigen negative patients, higher core-related antigen over 4 log was associated with more than 6-fold increase of HCC risk. Again, in a Taiwan study, more than 2,600 patients with HBV infection, core-related antigen level is an independent risk factor of HCC. The core-related antigen level of 4 log identified high risk of HCC, especially in patients with intermediate viral load. In patients receiving prolonged antiviral therapy with profound viral suppression, HBV DNA and S antigen level no longer serve as a HCC predictor. However, the several studies suggested on-treatment core-related antigen level may remain as an HCC predictor. The high on-treatment core-related antigen level are associated with increased risk of HCC development. This is a very nice review paper and tables from the clinical and molecular hepatology. Ladies and gentlemen, now I'd like to conclude my talk with these take-home messages. The level of alpha-fetoprotein correlates with HCC burden, tumor burden, but its role in early detection is still limited. There's a low sensitivity as well. PIVCA2 might be a better tumor marker than alpha-fetoprotein itself, and the combination with alpha-fetoprotein and PIVCA2 may enhance early detection of HCC. The highly sensitive AFP-L3 is a novel biomarker for HCC. The combination of 3 tumor markers is superior to that of any one of tumor markers alone. Lastly, the core-related antigen is expected as a new biomarker for prediction of HCC development in treatment-naive and antiviral-treated patients with chronic hepatitis B. I really appreciate your kind attention. Please keep your health against COVID-19 pandemic. Thank you very much again.